Hi, welcome to my channel. My name is Erica. If you're new here, welcome. I am glad you clicked on my video. Today I'm going to be talking about nurse stuff, so if that's your jam, stay a while. If it's not, I got tons of other videos. I have some plus size fashion, travel vlogs, all that jazz. Go check out those before you leave. And yeah, if you want to know a little bit more about my experience as a labor and delivery nurse, I guess it's like a Q&A, then just keep on watching. Okay guys, so let's get into it. If you guys don't know, my name is Erica. I'm a 38-year-old labor and delivery nurse. Yes, I said it. I'm 38 years old. I cannot believe that I'm going to be 39 in October. So yeah, if you didn't think that you could start a new career in nursing, you are wrong. I started in my mid-30s. I say mid-30s doing my prereqs. I am new grad nurse, new-ish grad. So about a year in. And it's possible, you guys. I have a family, I have kids, I have a husband, I have all that stuff, all those responsibilities, bills, car payment, mortgage, all that jazz. It's possible. You just gotta set your mind to it, get it done, and the next thing you know, you're gonna be rocking those fig scrubs. Figs are not for me, not for curvy girls. Sorry, figs, no offense, but I need more stretch. But yeah, so if you want to know a little bit about being a labor and delivery nurse, L&D nurse, OR PACU nurse, I kind of do it all. In my department, then just keep on watching. Okay, so did I say keep on watching again? I did. Well, you're gonna keep watching because you want to know more about being a labor and delivery nurse. Anyways, on Instagram and on Facebook, if you are new to nursing or being a nursing student, I never know how to say that. Student nurse or nursing student? Nursing student kind of sounds like nursing from, nursing here. Student nurse, let's use that, student nurse. I have a very large Facebook group. It's a support group. It's nursing student support group. I cannot talk today. I'm off of a night shift and I did get my booster shot. So I'm kind of like not right, but we're just gonna roll with it. I have a nursing student support group on Facebook. I will leave the link down below. We have 30,000 members. And it is a great place to vent, to talk about things, to ask for advice, homework help, dosage calculations, all that jazz. So make sure you go ahead and join the Facebook group after this video. So yeah, I asked all my peoples on Instagram and on that Facebook group page to ask me questions about being a labor and delivery nurse. I screenshotted them, so we're just gonna go, no particular order. Let me give you a little bit of background. I am a labor and delivery nurse. I do OR, PACU, pre-op, and L&D. So it's kind of a combination of roles. I do not do postpartum. I do not do NICU, and I do not do antepartum. Actually, I do antepartum. We can talk about that later. I do antepartum, but on a labor and delivery floor. I started as a new grad in a teaching hospital, in a very large teaching hospital. We have about 15,000 births a year, so that's about a classroom size, 30 to 40 babies a day. I have had 3 babies, 3 vaginal deliveries in one 12-hour shift, so it is a very busy hospital. I have learned so much that I'm going to carry through to any future opportunities that I may have. But let's get into the questions, okay? Let's get into the questions because that's why you're here. So these are in no particular order. The number one question that I seem to have gotten, how did you get into the field? Okay, so I happen to do my OB clinical in the hospital that I am currently working in. Highly recommend getting very close with your clinical professor. Not your professor, your clinical professor, the professor that is there at clinical with you, because they're there for a reason. They're there because they have OB experience and they have connections. They know people. They have worked there maybe, or maybe they're per diem. Maybe they can give you tips and tricks on how to make yourself more marketable in the OB world. We'll touch base on that in just a little bit, and I'll let you know how I made myself, or how I suggest you make yourself a little bit more marketable. I happen to use the connection of my clinical professor. I said, hey, I graduated. You had me as a student in your clinical group. And she's like, oh yeah, I remember you. Yeah. What's up? What can I do for you? I said, hey, I really want to do obstetrics. I want to do L&D. That's where my heart is. Do you think you can pass on my resume to your manager or somebody you know, anybody really. And she's like, yeah, sure, give it to me. And I asked her for a letter of recommendation. I attached that to my resume and all that jazz, and I applied for a position. It took a couple of weeks in order to hear a reply, but I got a interview and I got the job. So it's not impossible. You really need to use your connections. If you know somebody who is currently working in the labor and delivery unit that you want to work on, touch base with them. If you don't know anybody, go on Facebook, find somebody, ask them questions, because having a way in, a little window in, a little bit of opportunity for somebody to say, hey, I know somebody who's a new grad nurse, I think she'd fit well here, really does play a huge role. Now, it's not impossible to get a job in labor and delivery if you don't have a connection. You just have to be very persistent, and you should obtain certifications that makes you more marketable. So for instance, NRP, neonatal resuscitation something. See, this booster has me all fogged. Sorry. Okay, this is not becoming a vaccine thing. But anyways, neonatal resuscitation something. It's learning how to resuscitate a neonate or a newborn baby. Because not all babies come out screaming and kicking like we want them to. Sometimes they need a little bit of help. So that number one, get that. If you haven't gotten a job in labor and delivery, get NRP. Also, fetal heart monitoring. You can get the basic fetal heart monitoring, and you can get intermediate and advanced. Highly recommend you at least get intermediate, because you have to be able to read fetal strips in order to become an L&D nurse. I got my intermediate and basic and intermediate while in the new graduate program at my hospital, so they paid for it, which was great, and I took advantage of that. But I didn't have it, so it's not necessary. But if you want to make yourself a little bit more marketable, definitely get that. You also want to make sure that your BLS and ACLS are up to date. I had my BLS, and I had the opportunity to get my ACLS while in the new grad program, took advantage of that as well. But if you have that, that's less money that they need to spend on you. So BLS, ACLS, NRP, fetal heart monitoring. Highly, highly recommend those 4 certifications to attach to your resume so that you can be more marketable. Okay, so I think I answered that question, right? Yes, so how to make myself more competitive. Those certifications. People you know, letters of recommendation. Highly, highly recommend. Make sure your resume looks good too. You want it to pop and stand out a little bit. I'm gonna have a video following this video on how I structured my resume, so make sure you subscribe and, make sure you subscribe so you can have some tips and tricks on how to structure your resume to stand out. The next question I have is, why do some hospitals require 1 year of med search before applying to L&D, skills and knowledge, etc.? Okay, so I can't vouch for why they want to, but I can assume that they want you to have basic knowledge of med surg stuff. So yes, we're caring for laboring mothers, but a lot of these mothers have comorbidities like diabetes, hypertension, I mean, a slew of disorders, and they're pregnant and they're having a baby. So we have to make sure that we can manage their med surg side as well as their laboring event that they're having. A lot of our patients are on insulin drips, so knowing insulin, knowing blood sugars, AccuChecks, what's normal, what's not normal. I gotta go pick up my kid from school, so we're gonna do this real fast. Either that, or I'm gonna have to pause this video and return. See, the life of a mother and a nurse. You could do it, girls. You can do it, you guys and girls. He, she's, theys, thems. How about that? We are all inclusive here on this channel. So yeah, what was I saying? Oh, med surg. Yes. Oh my god, med surg. So going into a specialty, I didn't have any of those basic knowledges of IVs, how to put in an IV, how to set up your pump, how to prime a line, how to draw up meds. I mean, we did a little bit of that in not clinical, but like skills day when I was in class, but a lot of you guys are now doing Zoom class. So we have lacked those basic nursing skills that we use in labor and delivery as well. So I think hospitals want 1 year of med-surg because you have a foundation of basic med-surg skills and like basic hospital skills on how to put an IV in, how to keep your patient safe, like seizure precautions. You know, we have a lot of preeclamptic patients who need seizure precautions, and that's med-surg basic stuff. You know, pad your rails, bed in the lowest position, call it within reach, suction at bedside, all that jazz is basic stuff that you would learn on a med-surg floor. So do I think that you have to have med-surg for, you know, in order to get into L&D? Absolutely not. Is it going to make your life a little bit easier? Probably. But is it necessary? No, I don't think so. I learned all of those things during my 20-week orientation. It was kind of like a crash course, so it was very overwhelming, but it's doable. If I can do it, you can do it. So yeah, that's probably why I think they want med-surg. And remember, a lot of these hospitals that hire new grads are really investing a lot of money into you, and some facilities just don't have that budget to invest that much time. A med-surg nurse who goes into L&D has a much shorter orientation time as well than a new grad nurse. So just keep that in mind. All right, so do I float to a med-surg unit? I do not float at this hospital that I'm in right now. Although I will be I will be changing facilities soon. I'll get into a whole new video about that. Love the hospital I'm at. It's just, I have my own personal life needs and life work balance that I need, and I just need to change where I'm at to be able to obtain those goals. And we'll get into it. We'll get into it. No, I don't float. I don't float, but we do have something called a care team. So we do have nurses who train 1 year in a specific specialty. So it could be NICU, it could be transition care nurse, it could be postpartum nurse, it could be a labor and delivery nurse, it can be an antepartum nurse. They will train there for the first year, and then they will, after that year, they will train into another specialty where they can float between floors. So we have antepartum nurses who train in labor and delivery later. We have labor and delivery nurses that train in postpartum later, mother and baby. We have triage nurses that come up and do labor and delivery, vice versa. They deliver downstairs sometimes. So, you know, you're kind of a labor and delivery nurse downstairs too until we can get a bed, and often we are full and don't have beds, so they turn into labor and delivery nurses. So we do have something called the care team, which is great if you want to dabble into different things. My hospital that I'm currently at does not do LDR, what is it, labor delivery, postpartum recovery, but the new facility that I'm going to does. So I'm excited to learn new things and kind of have a change of pace, but we'll talk about that later. Let me see, anything, what was your hardest day in labor and delivery this past year and why? Okay, so IUFDs, intrauterine fetal demises, are the toughest time in labor and delivery. Often labor and delivery is a good, positive, like, yeah, I mean, it's happy. Most of them are happy moments, but then you have these moments where you have a 36-week gestation mom who came in for decreased fetal movement and the baby has passed away. And then you have to labor with them and deliver their babies and do post-mortem care. That has definitely been the hardest. I've had 3 IUFDs, 2 of them were vaginal, 1 of them was a C-section within my first year of labor and delivery. And the most recent one really like took a toll on me. Like, I did all the things I had to do. I kind of had to separate my feelings from my tasks, because if I didn't, I was going to just cry and break down, and I had to be there to support the parents, and the only way to do that was to separate my emotions, kind of become numb in that moment, while providing emotional support, hugs, and holding hands, you know, encouraging the parents to bathe the baby with me, you know, hold the baby, take pictures with them, and things like that. And in order for me to do that, I have to separate myself from feelings and my tasks at hand, and then feel later. And I mean, it's difficult because after a 12-hour shift, you're tired, and I've had 2 patients all night, and then I have this, and I actually had to deliver my IUFD. The physician did not come in time. Mom felt the urge to push all of a sudden, and baby was delivered in the bed, and I was there to catch, and so that was very difficult for me. As soon as I got into my car that night, that morning, I was still on day shift, so it was days. I'm night shifter now. I just let it go, for lack of a better word. I just cried and cried. I cried all the way home. I felt guilty for crying because I wasn't the one experiencing that loss. But being a parent myself, I can only imagine what that loss feels like. And I carried that with me for quite some time. I wish we had a debriefing moment. I mean, I was still with my preceptors, so we talked about it. But I think I needed a little bit more debriefing. I was able to come home and talk to my husband a little bit about it without exposing any HIPAA violations and things like that. And he just held me and hugged me and said that I did everything I could and all that. And so it was really, yeah, IUFDs are hard. Like, they're really hard emotionally and physically because, you know, you expect to hold a crying, warm baby, and when you're not, it's different. Like, it's different. It is. And I can't explain it until you experience it. And unfortunately, it happens so much in the hospital that I'm at because we are so high volume that it's just, and it always happens in threes. Like, we always have 3 IUFDs in 1 week, and it's just, wow, like, everyone's feeling it, and it's just sad. But I just encourage you to talk to your coworkers about it, debrief with them, let those feelings out, don't hold on to them. Ask for help when you need it, and if you need the time off, take it. Like, ask for it and say, I just really need the time off. Emotionally, I just can't do this right now. I wish I had done that because I really could have used some extra time to process what had happened. But I didn't. I was able to get through it. If it happens again, it's going to happen again. Not if it happens again, it will happen again. I will talk about it more and seek help if I need it. Definitely would do that. Anyways, I'm gonna go pick up my kid. I'll be back, and I mean, it's only gonna be 5 seconds for you, but we'll get back to the Q&A. Okay, I am back from picking up my child number 2. Back to the questions. Okay, so we're gonna try to get back into the happier things of labor and delivery. Let's see. We did competitive, how to make yourself competitive. My hardest day. Do I float? And now we're gonna do, what does a typical day look like for a labor and delivery nurse? Okay, so I usually have like my first night out of my string of shifts, which I try to do 3 in a row, or 2 in a row right now, but that's another conversation. I have pre-shift anxiety still, so I literally leave like an hour early so that I can drive nice and slow to work, and that way I can sit in the parking garage and kind of just like give myself a pep talk and say today's going to be a good day. It's going to be a great shift. We're going to have healthy moms and healthy babies and successful deliveries, whether it's vaginal or C-section, because sometimes, you know, sometimes C-sections are just inevitable. And then I go into work about 10 minutes early, get my stuff, my lunchbox. It's supposed to rain, you guys. It's Florida. It rains here every day. And then I just sit and wait in the lounge, put my lunchbox away in the fridge, put my backpack away, where I keep some of my supplies in the locker room, and then I wait for my nurse friends to come. We chat a little bit before our shift, and I clock in. Once I clock in, I take my water bottle to the nutrition room, or we can keep our water bottles there, and then I grab a little, let me see, it kind of looks like this, a little piece of paper. I take a couple of them and I staple them, and then I'm able to see my patients, who I'm going to be getting that night. And I always get 2, never 1. I always get 2. I always have 2 patients, and some people think, oh wow, you only have 2 patients, that's so nice. I'm like, no, I have 4. I have 2 I can see and 2 I can't see. So the two I can't see are the ones that always give me problems, and I can't anticipate something happening because it just happens. So yes, I have 2 patients plus my 2 little babies, and then I write down their gestation, so how many weeks they are, their G's and P's, so how many pregnancies they have and how many deliveries they've had, or yeah, that's right. So like if my mom has had 2 pregnancies, it's G2, and then if she's had 1 delivery, it's 1, so she's expecting a new one, so we're anticipating her to be a P2 eventually. Well, that's our goal, obviously. And then there's a little box on our, where it says like our assignments. It's on a TV. It's on a TV, so we can see our assignments, like what they're there for. So if they're pre-E, if they're on magnesium, if we need P's and RT there, if they're meconium, if they've had to treat blood pressures, if they're gestational hypertension, gestational diabetes, chronic hypertension. Just a little synopsis of like their main reason they're here, if they're an induction for something, if they have any like comorbidities that we need to be aware of. And then what else is on there? Their initials are there, their gestation, their doctor's there, or their team that is taking care of them. So I write that down. Their pediatrics, what team is taking care of baby when baby's born. And then we have if they've had an epidural or not. And I think that's it on that sheet. So I write down just a little story about them prior to getting report. Once we do shift change huddle, where we kind of get the gist of who's here, why they're here, and patients that we need to look out for, then we go into our separate reports. So I just pick a nurse, whoever's there, like let's go get a report. We go to bedside. We have like a sheet that has a story of their medical history. So like their blood type, their lab results for GC chlamydia, for rubella, for HIV, for hepatitis B, COVID status, their history, medical history, surgical history, if they've had abortions, spontaneous abortions, DNCs, any pertinent history that could pose a risk during labor and delivery, like blood disorders, anemia, things like that. And then we have their doctor, their G's and P's, their due date, and then we have a little list of events that happen right after delivery, right times and things like that. And then we just go over that, and then I check my pumps and my lines, ask mama if she's in pain, and then I go ahead and get report on my next patient. By then I've already logged into Epic and pulled up my strips in between the conversation, or if I had time before huddle. And then I go to my next patient, and then I get reports, same thing, ask her if she's in pain. I'll determine who I do my assessment on, and based on who is sicker. So if my pre-E patient is sicker, then I'll do her assessment first, and then I'll go do the other assessment on my other mom. But all the time I'm having my fetal strips up so that I can make sure baby's fine. And then once report is done, I do my assessments, I chart my assessments, I do my initial boxes in Connect or CPN where we do our fetal strips. And then after I had a moment to sit down, I will go into each patient's chart and then get the gist of their history, look at their lab results, look at any prior complications with a past pregnancy, and then fill in the blanks. It's kind of like detective work. Fill in the blanks, get any labs that need to be drawn, any medications that need to be administered. I write my to-do list down, all that jazz, just set myself up for success. And then I'm laboring with 2 patients. So if one needs an epidural, I go do an epidural, keep my strip up for the other patient. If that patient has needs, and I call out to my charge, hey, can you go to this room? This patient is calling out, or this baby needs to be, you know, mom needs to be flipped because we're having a variable or something of that nature. Once I have like a 10 centimeter, I then drop my patient who is not 10 centimeters to another nurse whilst I'm in my pushing phase. So I will push with my patient. We push up to 4 hours. I know it seems like a lot, but for some reason I have this cloud over me that I don't push more than 2 hours, maybe an hour and a half. Usually the first hour I have a baby. I'm flipping and flopping my mom back and forth, different positions. I prefer pushing with my patient than the doctor pushing. I like the midwives. Midwives are great. I love midwives because they're nurses. Like, they know what works. Doctors kind of just like to leave the patient laying on her back, and I don't want to leave her laying on her back because that doesn't really facilitate movement if baby's like facing up, sunny side up. OP is what we call it. So we need to do shift changes in the hips and things to make more room for baby sometimes, and there's different positions that we can do that. We can push on all fours, we can push on our sides, we can push with a towel pull or tug of war, different ways of pushing and different, you know, I always tell my moms, like, how this baby got in you is how this baby's coming out. So dads love to hear that. They laugh. So then once we have a baby, then we go into our recovery phase. At the hospital that I work at, I do both mom and baby. Most other hospitals you do mom or you do baby. So at this new hospital that I'm going to, I will have a baby catcher, which I'm so thankful for. And then we have, we're on a clock. We have a 2-hour recovery. As long as everybody is healthy and stable, then they can go up to postpartum. We do vitals on baby every 30 minutes for the first 2 hours. We do fundal checks on mom every 15 minutes. 7 times. I try to do 8 times, as many times as I feel like I need. I will do a fundal check. And then we do vitals on mom, 2 every 15 minutes, blood pressures and things like that, just to make sure they're stable, especially if they're preeclamptic, because if they're preeclamptic, they need to stay on magnesium for the first 24 hours after delivery. So we want to make sure that their blood pressures are stable, and if they're going to hemorrhage, you'll see blood pressures drop, heart rate raises, I mean, all these things. So a lot of things can happen post-delivery, you know, a lot of things can happen. And then once mom is fully recovered and baby is good to go, we go to postpartum, and then I say my goodbyes and I say I'll see you in 9 months, maybe for baby number 2, 3, 4, whatever. And then I go back downstairs, I go back downstairs, the postpartum is upstairs, and then I take over my patient and probably get a new patient, and most likely we'll get a new patient. And do that all over again. It's very fast-paced where I work. It's very high volume. It's very stressful sometimes. A lot of times it's very stressful. But if I didn't have a good team behind me, I honestly don't know what I would do. I would, my charge nurses, I have this one charge nurse who is amazing. And most charges are great, but this one, she is just amazing, and I'm gonna miss her so much. So much. So yeah, that's like a typical day. I do set up my warmer and all those things before. If my warmer's not set up when I get there for my patient, no matter how many centimeters she is, I will set up my warmer, my suction, and my like baby resuscitation mask and all that stuff before I go chart my assessment, because sometimes these babies be flying out and I want to be ready. I have my warmer, my blankets, all my supplies ready just in case I have a precipitous delivery, and it happens all the time. So that is what a typical day looks like, assuming none of our patients are, you know, COVID positive or have other things going on. I mean, where I'm at, there's no typical day because our patients are very high acuity. So not only am I a L&D nurse, but I'm also a med-surg nurse. I'm a psych nurse. I am a mental health advisor. I am a labor nurse, I am a postpartum nurse, I am all those things. So, Jill of many trades. So let's go on to the next question. Let's see, tips for getting into the field. I think I did that. Get those certifications. This is a brief overview of your work life. I did that. How many hours do I work? So I was hired to work 3 12-hour shifts, so 36 hours. If I'm now part-time status, and then I will be going per diem, but like I said, another video. Part-time is 2 days a week, so 24-hour period. I bunch them up together because I can't survive if I don't do that. I need to do that for my own sanity. When they're broken up, I just feel like I'm day, night, and just confused. And so for a full-timer, it's 36 hours, but you have to anticipate that you will have days where you are unable to chart, and you need to chart after you've given report to your day shift nurse or your night shift nurse. So the latest that I've gotten out is 9:30, and that was because our system, our charting system and everything went completely down, and we had to paper chart. It was a hot mess. It happened last week. I thought I was going to just, here's my badge, here you go. I'm done. But I made it through. We all made it through. We did it, but it was not a good time. Let me tell you, paper charting, bouncing from room to room because we couldn't see our babies. We had to listen to our heart tones to make sure baby was okay. No, not a good time at all. Okay, so we got that. And I think that was all the questions, you guys. Let me see. Let's take a look again. Do I love what I do? Absolutely. I could not see myself doing anything else. I could not see myself doing med-surg. I can't see myself doing anything but women's health, to be quite honest with you. I love labor and delivery. I love pushing with my patients. I love that moment of baby coming out and being put on mom's chest and mom and dad crying. When dad cries, oh, that always gets me. Always gets me. I love being a part of such a special moment. It really is fun. I really do like it. Anyways, I'm going to end the video here. If you guys want more Q&A questions, leave your questions down below. I'd love to do a part 2 for you. And I'll see you in my next video, guys. Mwah! Take care.